Okay. Hi, my name is Brittany Chambers. I'm an assistant professor in the Epidemiology and Biostatistics department here at UCSF, and my research focuses on understanding how racism is associated with adverse reproductive health outcomes among Black women. And my contribution to this project was working on the bibliography.
I'm Judy Auerbach. I'm a sociologist by training, and I am a professor of medicine at the University of California, San Francisco. My appointments primarily with interfaith studies here. And I work also as an independent science and policy consultant in all things related to HIV and HIV prevention, with particular interest in women in the U.S. And I also have worked primarily on the bibliography. At this point, what's nice is that we have a range of options for HIV prevention for women, not all of which are used as much as some people would like, but we're, I think, getting closer to approximating what we have for contraception, whereas there are a number of different kinds of methods available, at least in theory, to women that reflect different choices and options that women might have based on who they are. Their experience, in fact, with contraception might affect how they think about what to use for HIV prevention, what would be most attractive to them. And also different stages of life and different stages of sexual relationships. So we're getting closer to having much more of an array of prevention strategies for women. And these really range chiefly from, they're mostly biomedical or what are called biomedical technologies, whether that's a male condom, female condom, which is not very well used in the United States, but it does exist. Now we have pre-exposure prophylaxis through using antiretrovirals to prevent acquisition of HIV, and a woman can control that more than she could, say, a male condom. And with pre-exposure prophylaxis or PrEP, we now are seeing the potential for different modes of delivery. So right now, all a woman can take is an oral pill, but the researchers are looking at different kinds of administration, like long-acting injectables, and even maybe, gels and patches and the kinds of things that women have for contraception. So that's become a big area of HIV prevention for women. And there are non-biomedical strategies that are more structural and a little bit more afield that are harder to explain and get people to support that actually have some relationship to HIV prevention, like addressing gender-based violence so that women don't stay in relationships that can put them at risk of HIV, or making sure that women have better education and economic opportunities so they're not economically dependent on men and therefore also then staying in relationships or getting in relationships in which HIV might be transmitted because they're transactional relationships or because they're in violent relationships or whatever. So there's a big range of prevention options at this point, from biomedical technologies through to behavioral and social strategies. U=U is an amazing advance, and it's really the communications campaign and the advocacy campaign around what had been called treatment as prevention. So we had a lot of scientific and clinical evidence that now is indisputable that when a person who's got HIV takes their antiretroviral medications, gets on the medications, takes them consistently, and sees their viral load reduced and becomes what we call undetectable, that is, the virus is not measurable and is so small, if even at all existent in the body, that person can no longer transmit HIV sexually to a partner. So U=U in the prevention landscape is really transformative for transmission, meaning from an HIV positive person to an HIV negative person, because I, as an HIV positive person, if I take my medications correctly, consistently, and I'm able to achieve viral suppression, which most people are, not everybody, but most people are, under these medications, then I know now I'm not going to transmit HIV to my HIV negative partner, and that is hugely liberating from everything related to internalized stigma, social stigma. If the word gets out to everyone, it could even affect these measures around criminalization of HIV transmission. If the judicial system could understand that there's no likelihood of transmission, there's really no potential crime, so to speak. So there's this vast transition in thinking, particularly for HIV positive persons, hugely liberating, also just feeling like I can have sex in a much more liberated, friendly, pleasurable, fear-free kind of way. And for an HIV negative person in a partnership with someone who's HIV positive, for women or men, it's also very liberating to know that if, for example, a condom isn't used on an occasion, or becomes never used in the context of a monogamous relationship, then I'm not going to acquire HIV infection because the person using the medications isn't going to transmit to me. So it's a hugely transformative moment that we've got the science behind U equals U, treatment as prevention in that sense. There still are some questions that we are further exploring that are specific to women who are mothers and are breastfeeding. And there is some virus that may be residual in breast milk, or some that may be transmitted, that makes it a little bit different from sexual transmission. We also don't know a whole lot yet about U equals U in the context of injecting drug use, when you're not talking about the sexual relationships among drug users, but you're talking about, for example, sharing injection equipment. We don't yet know enough about whether antiviral treatment on the positive partner's part can prevent transmission to a negative person entirely for breastfeeding or for injecting drug use. So those are two areas where more science is needed. But on the whole, and particularly since most infection is transmitted sexually in the US and internationally, hugely transformative.
Well, I think that U equals U is so groundbreaking when we bring pleasure into the conversation, and particularly for Black women, and being able to explore their sexual options with their partners freely. And U equals U was allowing that to happen. So no longer worried about transmission of HIV, and can explore, as Judy mentioned, as relationships progress. And people are interested in no longer using barrier methods. This allows that opportunity.
Well, in brief, there are two things that I think are really key that we know about PrEP for women. One is, if taken as it's supposed to be taken, pre-exposure prophylaxis, currently only oral, pills is all we have at this point, but when taken as prescribed, it works, and it works nearly 100% of the time. The issue is more about why women are not taking PrEP in the first case at all, but also we know from the data over the years that you've mentioned, that have been mentioned, since PrEP has been approved for use in the United States and in some countries elsewhere, women have generally much lower uptake of it than do men, particularly gay men and other men who have sex with men. And so a lot of this has to do with two things. One is whether women even know about PrEP in the first case, and that's a function of what kind of communications messages are out there in the general public or in the places where women who either the public health system sees at risk, where they themselves see at risk, are hearing about PrEP in that way, and really more so whether any healthcare providers, whomever they see, their OBGYNs, their STI clinic people, their general practitioners, if any of them is even mentioning PrEP to a woman. Those two things we know have been quite limited for women relative to, again, mostly gay men. So what we know is that there is less uptake among women. There's also less uptake within the category of, well, both for women and for men, by African American men and women in the United States than there is for white and other men and women. So we still have those racial and ethnic disparities, even though in the US, when we think about women, and actually true for gay men too, African American Black women and Black gay men are much higher risk of HIV infection and have higher infection rates. So there is this disparity playing out about who is hearing about, has access to, and takes up PrEP. That is by gender and by race and ethnicity. It's also important that, like all these things, there's also some element of choice. So PrEP may not be something that everybody wants to take, and some of these cultural differences may play out in that. So if you're a person or you come from a group which has a bit of an antipathy around medical research or around taking drugs and you're suspect about medication, you may be less likely to want to take a pill for prevention. So I think we have to look at all of those dynamics a little bit more thoroughly for women, because there hasn't been sufficient research done to answer some of these questions, particularly about when there is information, what really keeps women from taking up the drugs. There are also, of course, structural issues around how do they even get the drugs to begin with for PrEP? Is their health system paying for the medications? They pay for the clinic visits and so on. The other category is where there have been actually a number of qualitative studies of groups of women around the United States that have asked questions about knowledge, attitudes, and perceptions about PrEP. And that's part of what we show in this bibliography is a number of them, and pretty much every day I see another new article. I'm kind of surprised they're still happening because I think they're all finding pretty much the same thing, which is women, first of all and foremost, are still not hearing about PrEP from any of their providers or in general out in the community. So that's the biggest issue. And then when they hear about PrEP, they seem inclined and overwhelmingly interested, not everybody, but overwhelmingly interested in the possibility of taking PrEP. But they feel like there's some concerns they still have around cost, who's going to pay for it, any side effects, and particularly drug-drug interactions if they're taking medications for other drugs. There's some concerns about, would their partners know about it, and what would that mean for them? So we find that there are a lot of the very similar barriers that come up across different groups of women who have been studied in these qualitative research. One of the final things that we know still is the case is that many women, particularly in the United States, do not perceive themselves to be, I shouldn't say particularly in the United States, this tends to be true internationally. Women who the public health system sees as at risk for HIV infection because of all the epidemiologic data don't often themselves perceive themselves to be at risk of HIV infection. Or even if they think they might be, it's very low on their list of priorities. And so that very much affects any interest or any kind of assertion of energy in trying to find out about HIV prevention methods like PrEP. About 16% of new HIV diagnoses in the United States still occur among women. And among those women, over 2/3 are African American or Black women. So we have a basic racial and ethnic disparity difference within the population of women who are getting infected. So that being said, although infection rates have gone down over time, there still is this great disparity in who is getting infected, and that very much then affects who might or might not have access to PrEP, who it's marketed to, what women hear about PrEP. That when you look at the PrEP prescriptions in the United States, about 95% of them are still among men. And African Americans who are at greater risk of infection have lower rates of PrEP prescription, whether they're male or female. And it's something like white men and women have 6 times more PrEP prescriptions than African American, Black men and women, even though they're at like reverse risk of HIV infection.
So when we focus in on the disparities in HIV for women in particular, results show that cis and trans women who identify as Black carry the burden of newly infected HIV persons. And this has been consistent over the years and is primarily driven by structural factors, which was already mentioned, such as racism, as well as access to services, and income also plays a role into that. And primarily among this population, there is also high rates of intimate partner violence that contributes to these numbers that we see. And then PrEP. And so, unfortunately, we do not see cis and trans, well, mostly cis women aren't really showing up in the PrEP uptake. I feel like trans Black women are doing better around the numbers, but cis women are not accessing PrEP at the rates that we would want them to, given the prevention up to 90%, well, up to more than 90% of people who take PrEP, they are not acquiring HIV. So it's a method that's highly effective and that's taken once a day, something that really could be taken in privacy, similar to taking like a birth control pill. Is something that your partner doesn't have to know that you're taking. So it's a method that could be used in confidence, and know that this is something that's really important among this population due to the stigma associated with HIV. as well as race-related stigma and discrimination. But I think the primary barriers is in the studies that we found related to PrEP use. Black women are underrepresented. So really we don't know a lot about PrEP among this population. In particular, what are the best messages that this particular group want? Are they interested in oral or other methods, as Judy mentioned earlier? So I think there is a lot of work that could be done in this particular area to make PrEP more accessible to this population. And as identifying as a Black woman, I think that, this is the thought of PrEP, is sexy. You can take it, you could go on and really focus on your sexual preferences, what you like to do, and still feel confident that you're protected from HIV. So it's a really good method out there, but just currently not accessible to populations that are most burdened by HIV.
One of the big changes that PrEP offers that has been a theme throughout HIV prevention conversations since the beginning, which is that we now have a method that is in the control of the user. And for women, that has been hugely important because for decades, all HIV prevention was dependent on men using, for heterosexual relationships, for men using condoms. And women just don't control that and aren't going to stick their nose, so to speak, are not necessarily going to attempt to control that given the dynamics of many of their relationships. And so we had talked for decades about we need methods under the control of women, and we looked and are still looking at vaginal microbicides or subtopical methods that a woman could apply herself. But even those can't always be done as stealthily as a woman might like, given the nature of her relationships. So something like an oral pill, a pill you can take once a day, after you brush your teeth or on some kind of regular schedule. You might pop a vitamin, you might pop a pill, and maybe nobody has to know. So there's something that just is very much more, PrEP is something that allows women much more control around HIV prevention than we have had before.
If you look at almost all sexual and reproductive health outcomes, you see this disparity where Black women carry the burden. An example that was brought up in preterm birth, we also see that Black women are at higher risk for giving birth to a preterm baby. What is universal across the field is that people are recognizing that stigma, discrimination related to social identities, such as racism, such as sexism, really play a key factor. And it can play out in several ways. So racism is a structural concept. And so policies and laws influence that in the context of HIV. When we think about clinical trials, we know that there is a history of the misuse of Black persons in studies. And so Black women and men are less likely to feel confident or confident that they'll be in a study where they won't be abused. And so that's an issue that comes up. And then also racism funnels down into implicit biases. So it could be, that providers' own bias towards particular groups, that they are more likely to offer treatment or less likely to offer treatments. So I think what we could do to kind of advance this work is to really focus in on, and we saw some articles like why aren't Black women being offered PrEP when they're talking with their providers, and then also what providers have this information to actually tell women about this. So really having providers who have specialties in both sexual and reproductive health as well as HIV work, and how can we make sure that people feel like they have providers and women have the information they need.
What we found from the literature and some of the articles in the bibliography tell us is that there is a lot of provider bias. And so part of the answer about why women aren't taking up PrEP is not simply just that they're not hearing about it from their providers, but why the providers aren't telling them about it. And some of that is that the providers themselves may not know and be very well aware about PrEP, but some of it is also this bias and judgment about who the women are that's actually pretty universal. We hear about that in context outside the United States as well. The judgments are made about which sorts of women should be having which sorts of sex at what age and in what context. And, you know, if they're doing drugs or if they're somebody that may have multiple partners, they don't deserve to have this positive health message and be told about access to prevention method that might actually enable them to have more pleasurable sex. So there is a lot of implicit and explicit bias, and those are very much affected by perceptions of race and class and educational level, and that very much influences why and how people, women in particular, do or don't hear about PrEP.
And I think that also brings up a key point when you said that. I feel like in both spaces, women aren't really centered at the root of this work. So if women were centered, then you would really focus on the woman and what type of experiences do you want, what access to resources do you want, and then also focusing on preterm birth is usually focused like on the baby, right, and not the mom. And if mom was healthy throughout her pregnancy, of course baby would be healthy, right? So I think that in this society, heteronormative society, that women tend to miss out on a lot of opportunities that
That's absolutely right.
could advance health.